Hello, everyone. I'll just give another minute or so we can get a couple more people in, and then we will begin. All right. Hello, everyone. Welcome to our industry showcase, 10 strategies from 10 years of experience. Today on March 25th, 2025. My name is Madison Lohman, and I will be hosting today. I would like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We gratefully acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. Please take a moment to share in the chat the territory you're joining from. On a technical note, please use the chat or the Q&A section if you're having any technical difficulties, and I'll be happy to help you out with that. We will also have Q&A time, so please submit your questions at the end or at any time. We will be using the Q&A and the chat section for that as well. Today's industry showcase is brought to you by LGI Healthcare Solutions. Thank you very much for sponsoring this session and bringing together this thoughtful discussion. We'd love to have you guys here. It is my pleasure to introduce our presenters today. We have Alexandre Couillard, who worked as an administrative assistant in the emergency department at Sacré-Cœur Hospital in Montreal while studying software engineering. This experience sparked a passion for solving complex challenges in healthcare, leading to his early involvement in a redirection project. After graduating, Alexandre joined LGI in 2016 in a technical role before transitioning to product management. Over the past decade, he has been deeply involved in the redirection solution and now serves as the assistant director responsible for this initiative. We're also joined by Francis Cuillerier, who is the Director of Clinical Solutions at LGI since 2020. Prior to joining LGI, he spent nearly 20 years as an emergency nurse at the University of Montreal Hospital Center, where he worked primarily in the emergency department, including triage and as an assistant head nurse. Following his clinical career, he specialized in care pathway optimization and clinical digitalization. He later served as a senior consultant in application synergy optimization for hospitals. For the past 5 years, he has been implicated to the development and enhancement of the LGI Redirection project, focusing on improving patient flow and optimizing emergency department operations through technology. So thank you both for coming today, and I will now pass the mic and the screen over to Alex.
Yeah, thank you very much, Madison, for the introductions. I'm just gonna request a screen share. It should be sent.
Yep, I accepted it, so you should be good.
Good. We can see the presentation right now.
Nope, try it again, maybe.
Okay, let's try again. Now should be good.
Yep, you're all good.
All right. So, hello everyone. Welcome. I'm glad to be here today. You've probably heard of the redirection concept, especially in the last few months. We've been involved for about 10 years now, and we kind of want to showcase the key principles that really ensure success of such a project. So we want to discuss of our experience with you guys and answer your questions also. So I'm accompanied by Francis, which will help, especially at the end for the questions. We'll go over a brief introduction and then talk a little bit about the challenges around emergency room overcrowding and redirection. Then we'll go through the 10 different strategies for a successful emergency patient redirection and have that period of questions at the end and a small conclusion. So as it was already explained, you can use the submit questions through the Q&A feature. And yeah, we'll just handle those at the end. So we are LGI Healthcare Solutions, a Canadian company based in Quebec for over 40 years. So we've developed quite a few healthcare IT products, so IT solutions for many different healthcare networks and organizations around the world. Many different products over the years. Today, we're focusing on our expertise in emergency solutions, especially from ER Redirect. And we are deployed in Canada, France, and Switzerland for that solution. So this all started because of overcrowded emergency rooms that have a lot of negative impacts. You know, it's nothing new. There's a lot of insights over the years in the scientific literature showing the different negative effects of overcrowding and misorganization of the patients in there. And one of the key aspects that is getting raised in those studies is that they need to find ways to alleviate the pressure. And one of the main aspects could be with non-urgent emergency visits. So we know there's a good portion of these patients that are considered non-urgent in the ER, but you kind of need a solution in order to assess who can be redirected to other resources. And one of the studies looked it up and relying on the patient themselves to assess if their symptoms are serious or not, if they should see another resource. It's pretty much the worst avenue. They are pretty bad at assessing their own symptoms and knowing if they are urgent or not. So they go to the ER not knowing necessarily. And even for the staff themselves, it can be pretty hard for them to assess this by themselves again. So this situation is not necessarily getting better. These numbers are from the Canadian Institute for Health Information. So the ER visits increased last year about 400,000, reaching now a big 15.5 million visits. And it's probably growing more this year too. And it was evaluated that about 15% of those visits are considered less urgent, or at least could be seen it in another facility other than the ER. We had a small dip during the pandemic where less urgent patients kind of avoided the ER a bit. The hospitals had bigger problems at this time, but now it's coming back up to around 15 again. So, you know, looking at all this, we know that there's negative impacts for the patients. There's longer wait times, patients leave without care, and not only the patients that are non-urgent, but all the patients in the waiting room gets impacted by this. It increases staff demands, and we know also it increases expenses for emergency department and the healthcare network, as less urgent patient costs more to be seen in the ER instead of a clinic or FCC. So, you know, in fact, all those problems, all those negative impacts could be alleviated a little bit with a redirection solution. So considering that situation, it would be a good avenue to reduce the pressure a bit by identifying patients who are less urgent and sending them to alternative resources. That redirection principle is even recommended by the Canadian Association of Emergency Physicians for years now, in fact. But you know, we need to find some sort of guidance and how to implement such a project to ensure that it's going to be successful and we get the most benefits of it for each of your healthcare organizations. So this is why we're going to look at the 10 important aspects or strategies to put in place such a program. So the first one, and probably one of the most important, is to use a scientifically based redirection model. It's, as I said, it's hard for the staff to decide on themselves who can leave. They are used on to the triage scale, in fact, but it was proven that the triage itself in the scale can be subjective. It varies from a nurse to another, and it's built to prioritize patients who stays in the ER. It's not made for determining who can leave. They need a clear decision-making tool and know what are the criteria to identify which patient can leave. And this needs to be done while maximizing the impact, the amount of patient that could be redirected, but minimizing the risks for them. So often when those models come into place, they evaluate the return rate, which is like in 7 days, like how many patient gets redirected but come back to the ER. And this gets analyzed. And the percentage of patient that comes back is really a key factor in assessing the safety of the model. So close to 0% would be too conservative as an approach. Not enough patients would be redirected. It would not be an effective program. Over 5%, it was evaluated that it could be less safe for the patient. So, having a model that is really studied based on medical science, in order to ensure that it doesn't vary from, a place to another, a local process or decision making, is really key to have something strong and safe for the patient. In our solution, the algorithm we use was built and studied by a university research center of Hôpital Sacré-Cœur of Montreal, which I used to work back in the days. So it was proven to be well calibrated to give great results and is replicable also to other hospitals. And the study proved that the model has a good balance of safety and impact. So this is really key. All right, number 2. So we need to leverage the most incentive for the partner facilities. We know it can be hard to convince FCCs and other partners, but they are really needed to optimize the first line of care and relieve pressure on the emergency rooms. There's a few key factors that help convince them to work with the hospitals on that aspect. The first one, being patients that are filtered by emergency services, it's a little bit less of an open-ended cases for them. It's more predictable, as you can see here. We can analyze the type of patients that they receive. And it's often smaller cases with quick consultations for them. It can be useful to fill in some gaps in the schedule and optimize really like the amount of patients that they can see per day, as they are, again, smaller cases. The solution needs to provide flexible scheduling tool to accommodate those clinics and entities. For example, being able to adjust the appointments at the last minute to fill in some gaps of their own clientele that canceled, and have limits and a lot of flexibility again. And one of the interesting aspects is that the patient that already have a professional assessment done during the triage at the emergency room, they get a quick appointment, they kind of feel supported, and they attend more to their appointment. So we've seen really lower no-show rates of the patients, redirected patients, compared to the usual clientele. So these are a few key aspects to leverage in order to make sure that the partners are helping the emergency rooms. Next strategy is to foster patient engagement. They, again, need to be well supported and guided so that they accept the redirection and they go to their appointment. We need to make sure that we provide a good experience for them. Sometimes some little details like giving them clear instructions, what to do if their condition worsen, where to go, what's happening with their evaluation, it really makes the difference. Overall, having a strong system in place in the ER kind of reassures them that they have been correctly assessed, and it's their They are a high priority to be seen by a doctor, but not necessarily in the ER. They can be seen elsewhere. So seeing that process, that strong model in that backs that flow, really helps them convince and they feel supported by the process. In fact, 95% of what we measured on our end of the patient expressed that they should support this program like everywhere. And also 94% of the redirected patient follow through and go to their appointment. So again, a really low no-show rate that we could observe. So helping the patient there. The next step, the fourth one, would be to also support our staff, the triage nurses that are basically doing this process and using the solution. So the reality at triage is kind of messy. It goes quickly. It's chaotic. Imagine there's a less urgent patient that the triage is assessing, but in the back, there's 2 ambulances waiting for other cases. We don't want to burden them with a heavy process, complicated tool, having them to look up in a binder and find the sheets of different options, almost do some sort of investigation on how to help this patient, get somewhere that is better appropriate. They need something easy to use in their usual flow. And that's really essential for adoption in the field. More simple, easier to use, will tend to have great success with the nurse staff that use this solution. It has been measured that this can be done. This is an additional step to their triage, of course. So they do the usual triage, but then they want to assess, can the patient be seen elsewhere and take an appointment? This can be done in under a minute. So this is an additional task, but really limiting that time that is added to their triage really helps out. The next strategy is to try to avoid the different solutions in the process. Again, avoiding context switching for the nurse or the staff that is involved. What is really important is to have the information on the patient condition that was just evaluated and deemed eligible, close to the resources available and the appointment taking solution. This really makes sure that they guide them to the right resources. It facilitates the data tracking also between the two. These aspects really helps out to make sure that it does not take too much time once again, but it's also well integrated for the whole flow of the redirection. And on that end, the next strategy is kind of related. Back to being able to leverage the patient condition to send the patient at the right place. We want to make sure that we actually, the partners, the clinics, FCCs, support the patient in the process. So let's take, for example, a patient that comes for a minor trauma at his arm. He's probably going to be requiring some radiology done on site. We want to make sure to redirect that patient somewhere that has radiology available and different other resources for each different consultation reasons. We don't want to send a patient at a clinic and then he has to come back to the ER because the clinic could not handle his case. That will put frustration on everyone, on the patient for sure, that he's getting played ping pong with. The clinic that gets sent patient that they can't handle, that's going to be frustrating for the nurse staff that has to see that patient coming back. So we really want to avoid all this. Make sure that each clinic with some particularities and specialization limitations are well configured in your system in order to make sure that you leverage the most you can of the resources available, but you send the right patient, the right clientele at the right place. Also being based on the reason, the proximity of geographical proximity of the hospital or the patient, that will also help make sure that we send the patient at the right place. Another win condition that we've seen on that aspect is giving the patient an appointment in like below 48 hours. Having an appointment quickly after, the patient will be more able to go to this appointment and will feel more supported by the process. We've seen that if the delay is too long, the patient might not accept and he feel that he doesn't see his condition addressed soon enough. He's still going to the ER to have some solutions quickly. So we need to provide that service. Number 7 is to foster staff adoption. So we already mentioned ease of use for the flow. That surely helps. But we really need to have a system that is built for the triage nurse that has minimal training. So something that is quick to learn, that is more open to the current situation or the current tools that you use in order to make them accept that new flow, that new task that they need to do to alleviate the pressure a little bit. In fact, we've seen that it's like having a securing system like that, something standardized, an approach that minimizes subjectivity, is reassuring for them. They tend to like it. It's not like varying too much from someone from a staff to another. And they see the value in that as soon as they use it. For example, the patient are less coming back and knocking on their doors for the triage and asking for reassessment on when are we going to be seen. There's a lot less frustration in the waiting room, so that really helps. It's worth it to redirect the eligible patients safely in those cases. So highlighting those values, involving the nurses in the change management, but keeping it really to a minimum in order to have good adoption is really the best. We measured on our hand for our solution, and it can be really successful. Like most of the nurses are really endorse the model and are satisfied with how it works. All right. So for the next part, number 8, leverage data in order to continuously improve. So let's say now the project is in place, it's adopted by the staff, it's easy to use for them. We kind of need tools to make follow-ups and optimize the solution. So we seen predictable cases earlier. So be able to track those and keep the negotiation and talks with the clinics in order to improve the flexibility and efficiency of all the system and the patient flow really helps. And be able to do this continuously by leveraging many tools is helpful. Some tools in order to do follow-ups on redirection, particular redirection that could be evaluated by revision committee. Tracking, scheduling, and partner offering in order to optimize that. How many time slots are needed per day for that particular kind of resources, geographically spread, maybe expand that offering with other partners. So all this is interesting to track and will help maximize the impact of redirection solution. Also, most of us kind of needs to see the results, have some reports done for management. So having some tools in order to export reports automatically and again, like see the data by period and everything is often one of the key success factors. We want to see the results. So yeah, good access to the data is important in those kind of solutions. Next one, minimize IT burden. So it's not a secret. Emergency department staff are overwhelmed. Everyone knows that, but often IT teams are too. In fact, they are often working on big projects, emergencies that they need to solve, and the window of innovation opportunity is often quite small. So really, like the strategy here is to look for a turnkey solution, SaaS product that is available out of the box without heavy integration with many systems and requirements, big change management, infrastructure to build, to support. So really keeping it at a minimal for the IT team is a winning factor. You also want to make sure that the solution is always available. There's no burden to operate that solution, track the reliability. If the redirection program is not working at some point, well, the staff will use it less. It becomes like, yeah, less reliable overall, and the solution might not work at the end of the day. So making sure that redirection is always available is important. And of course, nowadays we need a solution that is secure, that is encrypted. So yeah, that aspect needs to be covered also with the solution that you pick. This will make sure that, in fact, you can deploy quickly on the technical side of things. There, as soon as you have a few partners willing to help the system, it can be used right away without any long technical process, installation, and burden. So focusing on turnkey solutions on that aspect is really useful also. Last but not least, the strategy would be to develop a cooperative care framework with the collaboration of experts. So we know it's not easy to do. And in order to have a quicker impact, finding partners is really one of the key. It can be hard at first, and you'll need all the strategies possible to make this work. You sometimes need to think outside of the box, bring some sort of territory synergy, develop those networks, and often you will need guidance on how to organize those discussions, documentation also to use, how to communicate with those partners, and what kind of agreements to draft out. So having experts to help you navigate these networking challenges will be surely helpful. Both to get them on board at first, but also ensuring a smooth collaboration after. At LGI, we've faced this step in Quebec and in France also, and we want to help kickstart this elsewhere. We have experience with those kind of blocking factors and establishing the network at first, and again, we want to help. We had a few discussions in the last few months with some hospitals in Canada and different provinces. And although the reality of each province can vary, we are seeing a will and increased motivation to try to put a redirection solution in place and start, some trials, see where are the challenges, find the solutions. So we are looking forward really to help you navigate those challenges and find a solution and support the creation of those great networks to overall improve the patient flow. So there's quite a lot to think about with what we just discussed. These were like the 10 important strategies to have in mind to maximize the success of a redirection solution. This is all based on the work that we did for our product and implementation over the years. So it all started, again, facing the same challenges and having the same impacts for the ER that we wanted to alleviate back in 2015, where we worked with a university research center to develop the model and work on the software solution. We made it reproducible to other hospitals over the years, expanded the features to support all sort of different combination and configurations, and adapt a little bit to the different regions. So then we deployed in France and Switzerland also. And now we have more than 300,000 patients redirected with our solution, which is pretty good. We're pretty happy with the results. And applying those good strategies lead to great results for everyone involved. So it's quite a positive outcome that can be reached using those strategies once again. So for the emergency services and the healthcare network in general, well, of course, the patient flow is improved. Resources can be dedicated to urgent patients, which is the vocation of the emergency room, in fact. We see reduction in wait times for all the patients, reduced impact of congestion. There's a lot less of patients that leave without being seen, which can be dangerous for them to do so. So a lot of good KPIs that can be observed for emergency services. For the clinics and other partners, they can have some smaller and faster consultations. Sometimes, again, it helps fill in some gaps in the schedule and for the last minute cancellation and optimize their schedule. They still need some convincing to do, that's for sure. But, at the end of the day, they know that the system needs the first line to be involved there to help. And having, like a low no-show rate and elements like this is something beneficial for them. For the patients, well, benefits are kind of clear. They get no unnecessary wait. They feel supported by the process, reassured. A patient comes for mainly two reasons at the ER. The first one is like their medical condition. They need to find solution for their medical solution, of course. But they also kind of come for reassurance. Is my condition urgent? What's happening with me? Like, can I wait a few days or not? They aren't sure. So having that redirection process helps, find a solution for that part of the problem. Being evaluated by a robust system, they see that it's structured, and then they can have an appointment kind of quickly. So they tend to go to their appointment, of course. And when they are surveyed, they are pretty satisfied with the solution. Instead of waiting 6 to 8 hours in the ER, just go back to sleep. You can have an appointment, let's say, close to your work tomorrow morning or something. And that's really a key benefit for the patients, of course. For the nurses, well, again, there's some improvement in their quality of life at work, reduced pressure. The model is really built for their reality, so they feel like that it really fits in the system. And as I mentioned, as an example, there's a lot less frustration to manage in the waiting room because more relevant patients stay in the ER and the others are redirected to more appropriate resources in the end. We've also seen that the software can be deployed in a few weeks, and as soon as it's used, it provides really great impacts right away. So again, by minimizing the training and everything, you can have really great impact quickly. So that's pretty much it. We hope to help other provinces get these great benefits. We want to work together to find solutions and build the best redirection system for your needs. So now will be the time to ask any questions regarding those strategies, our solution, our experience, and have a little discussion together. So I would give the floor to Madison to help us coordinate the questions in the chat so me and Francis can answer them.
Yeah, for sure. And thank you very much. We've got a few questions here. Our first one that we've got is from Kim. They ask, has there been any evidence from the implementation showing that offering this service leads to an increase in volumes linked to people seeking to bypass the queue or get expedited care?
Yeah, interesting. So that was one of the questions we asked ourselves at first. So access to the first line of care can be hard depending on where you are, and the patient could see the pattern and go to the emergency room in order just to get an appointment then. For sure, the medical algorithm that we use filter the patients that are only eligible. So it's not always the care that it's not always the case. But this was measured in our previous studies, and it was really marginal. So, Francis, I don't know if you have the number at hand, but I think it was like below 1% of what they observed.
0.2%.
0.2%.
Yeah,
so
it's measured.
Yeah, so it happens. It's marginal. There's some strategies also we can discuss to alleviate that and track those kind of patients that abuse the system. But usually, it's pretty marginal.
Awesome. We do have a question from an anonymous attendee. Have there been unintended consequences of EDs implementing appointment booking? I'm worried about EDs becoming a place for patients to come and get appointments booked rather than looking themselves.
Yeah, kind of similar to the previous question. Again, like we don't want to make the emergency room like an entry point for appointments. We've seen stats around 50% of the patient are non-urgent. They are currently going there because they lack other type of resources, and sometimes they kind of don't know if they are less urgent. As I said earlier, especially parents of children, their children is not doing well. They go to the ER because they don't know. Sometimes they assume they're gonna have all the resources available there, but it's not the optimal way, and it can lead to over treatment. Also, we've seen those studies. So we need to redirect those to the different clinics, and we can see maybe in your experience you've seen some patient that tend to go to the ER because they want to go elsewhere, but what we've seen is pretty marginal. I don't know, Francis, if you want to add in anything to that.
No, it's perfect. Everything have been said. It's we know it can be a problem, but it's a very marginal problem, so you don't have to worry about this. Uh, and in a little bit of education can just bring the patient to do correctly their emergency visit for the future visit.
Yeah, in the best world, like every patient could have access to all the different entry points in the healthcare system and go directly to the right resources. Fact is, it's not there yet, and yeah, they need some sort of guidance, and that is really working well when they are assessed by a triage nurse for their condition also.
Yeah, and then we have a question from Anjali, which is, I think, a little bit similar, but you might be able to expand on it too. Are there any plans to expand the solution in a way that provides greater empowerment and accountability for patients at an earlier stage? Specifically, could patients be redirected before entering the ED?
Yeah. So we've seen some different projects that were started with other lines of input. So instead of going straight to the ER, they kind of get bypassed, use the solution to assess the patient eligibility to be redirected elsewhere. We've seen one project with paramedics using this with patients at home also. So some programs, instead of sending them by default to the ER, they could talk to a nurse and do some assessment with the paramedic and the nurse in order to establish if they can be seen elsewhere. So these kind of approaches exist. And yeah, the earliest we can use the solution like this, a redirection program, the best it is, so that we avoid that they go to the ER at all. But again, what we've seen over the years is that there's always a proportion of patients ending up at the ER, and this is where we need to redirect them primarily.
Awesome. We have a question from Ruben. How many facilities currently deploy ER redirection as part of LGI's network?
Yeah, so in Canada, we have, I think, around 12 hospitals or entities that use the solution. In France, it's even more than that. In Switzerland, we have one hospital. So it's kind of in a recent expansion. The thing is that, we are not implemented elsewhere in Canada outside of Quebec yet. But there's a number of hospitals that are interested. We've seen, again, like a willingness to try and implement a good redirection system, especially recently. We've been working with a few clients to finalize contracting and are going forward with the next steps to implement. Quite a few within Ontario, a few in the West also. And yeah, so we're excited for the next months in order to expand that solution to other provinces.
Awesome. And then maybe a little bit more from one of Ruben's questions was, could you talk about the work required to implement your systems in other jurisdictions? And they specified like France and Switzerland. So what was that like?
Yeah. So of course, it's an initial challenge to reach those new regions. So there was a little bit of work to be done, convincing doctors, changing a bit the way that it's perceived as a program. But yeah, there was also a small adjustments to the algorithm done in order to support well those new regions. And working in collaboration with the doctors there and the emergency services, we were able to adjust and input that program in those regions, and it's working quite well. I don't know, Francis, if you want to add up on like the different aspects that occurred.
Maybe we should add that sometime we have to tweak the pathway because in some region, like practitioner nurse can treat some mental illness minor problem, but in other territory not. So we just have to tailor some by their consultation reason who can manage the client after his emergency visit. So maybe just a little add to what you said, Alex.
Yeah, there's a lot of creativity that we can figure out in your region. Like sometimes specialized clinics, points of services. Like we've seen some entities that could do. We support about 50 reasons of consultation in our redirection system. There's quite a few of these that can be sent to specialized clinics. So it kind of depends on the region, but being creative, have a system that is flexible enough to support those smaller or different entities really help. But yeah, we are again looking forward to seeing the different region challenges, and we have overcome them in France and Switzerland. So we surely can do that in other provinces, Canada.
But
it's even
we can
closer
add,
to us.
if I can add, Alex,
Yep.
A minor problem in Quebec is a minor medical problem in France. It's a minor medical problem in Ontario. So we start on that base.
Yeah, it's the same basis, of course. And yeah, we build up the little adjustments for the network over that.
A human body is a human body. Just the language you change a bit and the law. So
yeah. Yeah.
Awesome.
Next question, maybe.
Yeah, we have a couple of questions that are similar. One from Kim and Cindy, both asking, has this been studied or implemented across both urban and rural emergency departments, or is it just a specific area?
Yeah, so we've seen both, especially in France. It can be different. In an urban region, there's a lot of clinics, often like a lot of possible resources, so it kind of gets easier to find partners. In rural areas, it can be a little bit more tedious to have alternative resources, but we've seen it work also. Like it's again some sort of collaboration that we need to help you out build up with those clinics, and again leveraging other smaller entities that could see that could help out the emergency rooms. And sometimes also the patient kind of goes to the ER that is, let's say, closer to their home or closer to their work, and then they could have an appointment further down. So geographically, we would have to look into it. For sure, the rural regions are a little bit harder to find partners, but creative solutions can be found there too, and we've seen some success.
Awesome. We have a question from another anonymous attendee, and also another question from Colin that are very similar. Could you elaborate a bit on the liability involved for nurses or whoever is the first point of contact when they are redirecting patients? And then the anonymous attendee also says, and I believe you mentioned that CAEP endorses this. Could you share that information?
Yeah, for the CAEP endorsement, maybe we can reach you out and send you the links. I think it's back in 2009 even, Francis, that they kind of backed.
Yeah, it's all, but they support the redirection to prevent overcrowding emergency.
Yeah, it's like
They're
the
not
principle behind
our
it.
solution, just to be clear on that.
Yeah, they kind of let the healthcare organization figure out a way to do this safely, which is where we can come in and help. They just support the principle behind using that relieve pressure a little bit. For the reliability kind of things for the nurses, maybe you can elaborate at least what happened in Quebec on that aspect.
Yeah, the algorithm is measured and it's safe for the patient if they have an appointment within 48 hours. But at the end, it's always the nurse judgment prime on the algorithm. Even if the algorithm said that the patient can be redirected, if the emergency nurse at the triage have a bad feeling about the client or the patient, we said keep the patient at the emergency room.
Yeah.
It's always the human judgment in front of the algorithm.
Yeah, it's a decision-making tool, so it helps
Right.
them. It standardizes a little bit the approach, but at the end of the day, they can decide to keep a patient that that they judge should stay. The alternative is to try to input redirection without those guidance. So it's even worse. They kind of go with the flow, and each nurse could have a different perspective on things. So having again something that has been studied and medically backed really helps out, convince them to do that in practice.
And I saw a lot of question about the self-assessment of the patient, but it's for now we measure that it's better to have a human in the loop because patients are, like Alexandre said before, patients are often anxious when they come to the emergency room, and some people are over, they think their problem is bigger than it's actually is, but and the country and how you said contraire in English?
In the contrary, yeah. On the other side,
contrary.
patients maybe feel like they're quite fine, but it could hide something bigger. So yeah, again, and we've seen some patients that tend to lie, exaggerate, as you said, in order to be seen quicker. So self-assessment tool for now, it's not there yet. We've seen some AI perspective too that they can adjust the questionnaire. But again, like we feel for the current results and evaluation, the best results are with a professional assisting during the redirection process, which again can be done in a minute. So not too bad on that end.
Awesome. And then Gord asks, who pays for it? Is there a direct benefit for the ER department?
Yeah, so the solution in our case, it's the hospital that pays for it. It's free for FCCs and partners. We don't they already need to be convinced. So it's really the hospital that pay. It's not such a big costly solution. It's kind of simple to implement too. But yeah, the benefits for the ER, as we saw a little bit, it's really on the key metrics for their emergency room. So less wait time for the patient, less patient that leave without being seen, less frustration in the ER, better efficiency overall. And there's also some financial, incentive, but at a bigger scale, I would say. Like for the health network, it costs less to see a patient in an FCC compared to the emergency room. So maybe not directly the hospitals that feel this change, but as a collective, we kind of want to optimize also the financial aspect of seeing the patient at the right place. So yeah, overcrowding has a lot of negative impact. This is where it really helps.
Awesome. And we have a question from Elliot and then another one from Dan in the chat who are kind of asking similar questions. Are these strategies intended exclusively for implementation within the emergency department, or can they also be applied in other healthcare or non-healthcare settings? And then Dan specified in their question, have you had any EMS services that have been able to redirect calls and things like that?
Yeah, so our experience and the study that proved the effectiveness and the safety is done in an emergency department setting, but we've had discussions in other areas that it could be leveraged. In sometimes big clinics that could help with redirection of the patient to send at the right resource. With the emergence of nurse practitioner that Francis said earlier, that's something that they can see about. I think the studies said that about 30% of the patient of our supported consultation reasons. About 30% of those has to be seen by a doctor, but the rest, 70%, was able to be handled by a nurse practitioner. So maybe there's some sort of leeway there to work with that solution. For the EMS, again, not necessarily directly. There's some criteria that has to be evaluated by a nurse. Some others no. So there's flexibility in the algorithm. There could be a subset of the algorithm that could be used in another setting. We would have to discuss those areas with you. So if you want to reach out, we can talk about these and see where your use case is, where you see benefits possible.
Awesome. And we have a few more questions. I think we can probably get through most of them. So Riza asked, is this software integrated with EMRs, including Cerner or Meditech?
Yeah, so Cerner and Meditech in Quebec are not really used. In France, I think they have pretty much different solutions. We are not integrated directly with those. Again, it's one of the factors that actually helps kickstart the project. Those kind of integration can be a burden for the IT teams and for the project management perspective. The solution works independently without requiring those integration. So basically, we handle the confirmation. That confirmation number can be used in your usual software like Meditech just to trace back which patient had which redirection process done. But it's not a heavy integration that is required at all. If you see that it would be something to explore, again, you can reach out to us and we can see. We are open to being more flexible with different solutions, but just know that it's working well without that.
And then I think we'll do one more question.
Yeah, maybe one more.
Yeah. There is a question from Alana, and then there's also one from Marie-Eve that I think are pretty similar. Alana asked, was there any resistance from Emerge physicians? And then Marie-Eve asked, what was the feedback of triage nurses? Did they have any delay in pre-triage time? So what was the feedback from people?
Yeah, we've had resistance from emergency physicians at first. There was discussions done to convince them a little bit because it's smaller cases, easier to see. Sometimes, quick money to be made for those cases that kind of gets sent away. But really, it comes back to bringing the ER to the main purpose, which is seeing urgent patients. And that pushback that we initially had, once there was discussions, convincing, and they tried it out, it became really marginal. I think there was like one doctor in our whole fleet of clients that was still against the principle of it. But they need some convincing at first, but they tend to see the benefits quickly. I don't know, Francis, if you want to add up, and also for the triage nurse experience.
Maybe in the presentation you show some stat about the nurse.
Yeah.
They like the solution and they feel safe when they use the algorithm. Yeah. We have this. Yeah.
We did a survey with the nurses a few years ago, but still, they were really pleased with the solution for the nurse staff.
Yep.
Again, it's built on the field. It was built near them. It's easy to use. Yes, it's like an additional process of a minute or two to evaluate the patient that can be redirected, but they see the benefit in the end. This was really a key factor of our conception of that solution. Make it easy to use for them. So I think we had it pretty bang on that. We have new modules also over the years in order to split the process and leverage administrative agents for some appointment taking stuff if they want to optimize even more the time of the triage nurses. So all this is possible, and we can look that up together.
And if I can add, Alex, the question of Marie-Ève for the pre-triage, the solution can be used at the pre-triage as well if it's a very, very easy a reason of consultation. If they have to take like vital sign or anything else, it goes at the triage step and not at the pre-triage step. So I just want to add this with the question of Maria.
Yeah. Good. Thanks. I will wrap things up on our end. So thank you very much for being here. I know that we had quite a good attendance today. So again, we see great momentum to try to put those solutions in place. And we want to help you guys put that redirection model and solution. As we're now going into other provinces, we understand it's new regions. We believe in the product. We are willing to provide a trial period for the first few clients that would like to implement it in their region. So start discussing with your colleagues, contact us for more information. We can book a discussion together, demos, and help you overcome your challenges. If we didn't have time to answer your question today, or if you have other that come in mind, reach out to us. You see here on the screen Lucky's coordinates, so don't hesitate to write to him. And we will also follow up with you. Lucky will send you a reach out in the next few days. So thanks again for being here. And yeah, back to you, Madison.
All right. Thank you both very much. I'm just going to share my screen again. And I will do, oh, not that one. So sorry. This one. That one. All right. I'm going to do a quick poll, but I also do have this survey here. If you want to follow the QR code here, I will also be sending you an email after the industry showcase is over. So if you could please just take a couple of minutes to answer that survey as well as the poll that was just put up on your screen. It really helps to give us information about future industry showcases, what went well, what didn't go well, and to go further from there. I want to thank LGI Healthcare Solutions for joining us today and sponsoring and hosting this industry showcase. It was amazing. You guys did a great job. So thank you very much for that. We also have Oh, sorry. We have our membership page. So if any of you are members at Digital Health Canada, please go to our membership community page. We have community of actions that you can join. We have different groups. We have resources and news updates that you can look through on our community. And we also have our Digital Health Canada podcast, which is a monthly podcast that you can find on all of any podcast platforms. So please feel free to find that QR code there on the screen as well and find and follow it. So once again, thank you very much to LGI. We really appreciate you guys coming out here.
Thanks
Many
to
thanks.
Digital Health. Yeah, thank you, Madison. Have a good day.
Awesome. Have a great day, guys.
Goodbye.